recorded on Yugambeh land. We acknowledge their traditional custodians, elders past and present, and all Aboriginal and Torres Strait Islander peoples. Please note that MP in Progress is an independent project and is not affiliated with any health service organisation. To ensure confidentiality, all identifying features have been removed from the case studies to protect patient privacy. The content shared here is for teaching and learning only and should not be used as a substitute for professional medical advice or evidence-based clinical decision-making. Always refer to current guidelines and collaborate with your healthcare team in practice.
You ready for this? Sure. Welcome to NP in Progress.
Thank you.
I have Kate Dale, who I'm a bit of a fangirl. I'm sure that you've got more than just me as a fangirl. I guess I really look up to you as an emergency nurse back in the day when you were doing that. Then you've transitioned into a nurse practitioner a few years ago now. You can tell us about that soon. But you're now the trauma NP where I work, and super niche position that you created yourself, which is really exciting. So I ask everyone, can you tell us where you started your nursing career and how you got into NPs?
Yes, I did my nursing degree and then did my grad year and then did 12 months in the emergency department. And after that, I went up into Cape York and worked on Aboriginal communities for 12 years. Had my babies up there and decided after 12 years that was probably long enough to be away from home. So decided to come back and thought, what am I going to do now from a work point of view? And I thought probably having worked in ED already, that ED and the rural and remote field was probably the best fit. So came back and got a job in a big emergency department, and whilst working there really missed the autonomy that I had up in Cape York. And there was this thing called the nurse practitioner model that was coming through the emergency departments, and we had a couple of NP, or one NP in the emergency department that I worked in, and then a couple coming through the ranks, and thought that looked probably like the best fit for me. So went on to complete my nurse practitioner training in the emergency department.
Did that take you 1 year or 2 years?
2 years, 2 years part-time.
Did you have nurse practitioners, or was it more like a medical model that was supporting you?
So I had both. I had a paid candidate position, which gave me 2 days paid training a week. I went through pretty much by myself. I don't think there was anyone else that did the training with me. The cohort before me had about 4, and then my year was just me.
Okay.
I was supported both by FACEMs and emergency department nurse practitioners, which was great.
How long did you stay in emergency for before you sidestepped into a role that you created for yourself?
Well, the thing was, when I finished my nurse practitioner training, there wasn't any jobs. There wasn't any NP jobs in East. Part of the new build for the hospital, they decided that they wanted the hospital that I worked in to be a level 1 trauma centre. And to do that, you had to have a trauma service. So they advertised a trauma CNC role that I was interested in. I'd always sort of had an interest in that. When I did my nurse practitioner training, you had to, and you still do now, have to develop a model of care. And my model of care was focused around trauma in the emergency department. So I applied for the job, got it, and then started to build the trauma service where I work now. And I remember in my interview for that role, telling the nursing director that was interviewing me, the nursing director and the director of nursing, that I'd just finished my NP training, and that if a job came up that I would probably apply for it in the emergency department. And the nursing director said to me in that interview, well, this role would make a great nurse practitioner role. So from the get-go, I had executive support, which was, I think, key to me then being able to submit a business case and a couple of years later have my position converted over to a nurse practitioner position.
Can you tell us what the day in the life of Kate Dale, the nurse practitioner in trauma, consists of?
Yeah, so every day is different. I work within a team of trauma specialists now who round on trauma patients twice a day. I run an outpatients clinic on a Thursday morning where I see all of the patients that need to be seen post-discharge, mostly the post-surgical patients. So we do a lot of rib fixation. So I'll see those patients post-op, and at certain time points throughout their journey, I'll see anyone really that needs to be seen. Monitoring of pleural effusions. I'm just thinking of what I saw this morning. Monitoring of pleural effusions. A couple of rib fixation patients, post-splenic embolization patients, anyone that needs to be seen post-op, really, they'll come back to my clinic, which is a pretty unique thing. In Australia, trauma follow-up care is very disjointed. It's often complete by teams that don't know the patient and not by a nurse practitioner. The nurse practitioner outpatient trauma follow-up clinic is a really unique part of my role and something that I'm very proud of and something that other centres across the country are looking to roll out now. So there's a whole lot of momentum for the trauma nurse practitioner model throughout the country, and particularly in the outpatient space. So that's pretty cool.
Why do you think that there's a growing need for that?
Well, our research has shown that trauma follow-up is very disjointed as to when it occurs, who it occurs for, and who does it. So I think people are they've looked at the success, and we've been able to publish the success of our clinic or my Trauma Connect clinic, and they're looking at that as an option now. So it's very disjointed, and it just doesn't have to be like that.
Yeah, cool. I guess the point of this podcast is learning clinical reasoning and making sure that you're moving to the correct diagnosis. Trauma is really specific. It's primary, ABCD, and then your tertiary survey later on.
Yep.
Can you talk us through really what the difference is and when these two separate, I guess, systematic reviews should occur?
Yeah, so they are different, but they're also very similar. So in trauma care, it's good. We've got really systematic ways of working through our surveys. So we have the primary survey that should be complete within the first 5 minutes, really, of the patient entering the resus room. And it's a quick ABCD assessment of the patient, ruling out any life threats. And then we move on to, which also includes adjuncts like the chest and pelvic x-ray and EFAS now, which has been a bit of a game changer. Once we've done all of that, we can start thinking about our secondary survey and just nutting out any other injuries that they might have, which is mostly going to be orthopedic type injuries. And then that will inform what imaging we go on to do. So whether that's a whole trauma pan scan or selective CT scanning plus other orthopedic x-rays. Once we've done that, the patient moves to the ward or into the intensive care unit, and within the first 24 to 48 hours, we come along and try and complete a tertiary survey, which is a really thorough head-to-toe assessment of the patient, looking at all their skin, all of the joints, trying to weed out anything that we might have missed in the emergency department. And it's not that we missed things in the emergency department, it's because when the patient's in the emergency department, they have different priorities. So the patient might be bleeding and be hemodynamically unstable and need to be rushed to theatre. So it's not that we missed that broken ankle, it's that the patient had a more demanding priority at the time and had to be moved on, and their journey progressed in that way. So we don't like to call them missed injuries. They're like a delayed diagnosis, I guess. So sometimes the patient might not even get a secondary survey in the emergency department because they need to be moved on. That's why we have a trauma service to come along then the next day and tidy all of that up for the patient.
In terms of the head-to-toe assessment, we had to do that in our first semester. So you're essentially an expert in that head-to-toe assessment. Is there a systematic process that you use that you think works for you best? You've probably adapted over time.
Yeah, I've adapted it for me. But if you watch me do a tertiary survey, I'll pretty much do it the same every time I do it. And that way I know I'm not going to miss anything out. So starting at the head, scalp, moving down to the neck, moving down the back, then coming back to the face, doing a cranial nerve exam, and then moving down the body, making sure you do chest, abdomen, pelvis, every joint, every in the upper and lower limbs, including looking at the skin and not forgetting like a full log roll of the patient as well. So yeah, as an NP coming through the system, you'll find your own way of how you do your clinical assessment. And I find even now in my practice in ED that I do the same now for every other assessment too. So it might be ENT. I start behind the patient, then move to the front, and I do it the same every time, and that way you don't miss anything.
I guess we probably should mention that you've stepped back into ED nurse practitioner now as well. And
yeah.
Do you think that's a really nice work balance?
Yeah, so I did that for a few reasons. I started to think about the future, and I thought I might down the track want to do a bit of locum NPing, and the ED skill set is really the best fit for that. And I started my NP training in the emergency department, but didn't really consolidate that at the time because I moved into the trauma world. So I really wanted to go back and consolidate that skill set, which I feel like I'm I've been able to do. And the other part of it was just trauma. While I love my job, was just feeling a little bit about Groundhog Day. And I wanted to challenge myself again. And there was an opportunity to move some of my FTE to the E. So that's what I did. And it's been excellent. It's a great fit. The trauma and the ED model fits really well together. Each role makes me better at the other role. And it's worked out really well.
At the beginning, when you transitioned back into ED, did you pick patients that were out of your comfort zone?
Well, you sort of have to. You can't really pick and choose who you see. You just need to pick who needs to be seen next. And whilst I enjoy seeing the trauma patients in the emergency department, that's not who I needed to build my skill set back up for. So I was really cognizant of to pick who was next to be seen, not the trauma patients.
Okay. And what would you say your weakness was if you could give me two?
Oh, the medical stuff, headaches, syncope, that type of thing. Medical and cardiology. I really miss working in ED as an RN with the big cardiology cases. And that's definitely a deficit for me now. So the medical stuff and cardiology.
There's actually a lady who inspired me to make this podcast. Her name's Dr. Nicola Cooper, and she writes this book called The ABC of Clinical Reasoning. And fortunately, she said yes to a podcast with me. And she is all about evidence-based practice. And she's released a few podcasts about headaches and making sure that you have this open dialogue and talking about meningitis, and that a headache or photophobia might not be the actual illness script that makes it meningitis. I just think it's really interesting finding out about all of these things. Yeah.
For someone that works in the emergency department, you don't want to miss the big ticket items. So I guess for each presentation, you have a list of red flag presentations that you just don't want to miss. And then your decision making and your questioning is around those.
Learning that skill is just so learnt, right? You just can't read a textbook and be like, yeah, I'm going to focus on this and I'm going to put this in and ask every time.
Yeah. It's experience and it's pattern recognition, and you just have to get in there and start seeing patients and start weeding through.
Yeah. You work with a team, mostly surgeons. How should I say this?
They're different to FACEMs.
Yeah.
Yeah, who are used to working.
Yeah. And we know where we work with our FACEMs in ED, they're very colleagues.
Yeah, there's a flat hierarchy.
Yeah. And the surgical world, it's kind of that hierarchy. But you're so well respected by your colleagues, the surgeons. You've got such a great name. Was it always like that, or you had to build from time?
I guess when the surgical side came to the trauma service, the service was already a little bit established. So we started with a director of trauma, 0.5, who was a FACEM, and the nursing side of the service. And that's when the surgical side came. So we already were up and running and were seeing patients and had a feel for what we needed to be doing. So I guess the surgeons then just came along and were able to witness and see what we had built and see how we did things. And the relationships just sort of really built from there. We were able to demonstrate that I knew what I was doing, and that's how the respectful relationship began. So it was a little bit different to me trying to fit into the surgical world. They came and were able to witness what we were doing, and it's grown from there. The surgeons I work with most closely, very respectful of the nurse practitioner model and the other nursing model throughout the service, which is something that I really try and protect, which then hopefully filters down to the more junior doctors. I find that it's not the consultants that I have issues with. I find that it's the more junior doctors who in the trauma service, they rotate every 3 months. And some of them have never come across the nurse practitioner model before, or might have heard of it, might have been referred by ED, but don't really know what it is and don't really know what we do. I find that with my job in the trauma service, our role conflicts a little bit. I'll lead the ward round a lot of the time, and in the surgical world, they're probably used to doing that. That's just one example. I spend a lot of time trying to educate the junior doctors and demonstrate to the junior doctors what my role is and how it does differ. There's no competition there really. And by the end of their term, we're normally good friends. Most of the time.
We love talking about a case because you can make it really applicable in your mind on how to learn. Can you talk us through a case that's been meaningful to you or that you've learned?
Yeah, we had a case recently that I reflected on a lot, and it was a 21-year-old male who was involved in a high-speed motorbike accident. who came to us with multiple injuries, including some C-spine fractures. So head was okay, bilateral comminuted intra-articular distal radius fractures with which were both cast, a few rib fractures in the chest, belly was okay, pelvic fracture, and then a ankle fracture on one of the sides, which was also cast. So you've got a 21-year-old multi-trauma patient lying flat on his back in the bed, lots of pain with casts on 3 limbs. And in the emergency department, he'd had his neurology assessed a couple of times by the specialist teams that had been referred, who had documented differing opinions on the neurology. He was sent to the ward for an MRI to happen the next day with full spinal precaution. So he had a collar on, lying flat in bed. We go and see him for a tertiary survey the next day, and it's documented all along in ED that he's a difficult patient to assess, in lots of pain, complicated by the fact that he's got all these casts on. So go and see him the next day for a tertiary survey and find the same thing, really, really difficult to assess, in lots of pain, which we tried to control and then reassess, but still really difficult to assess. And his assessment was confused by the fact that he had the casts on, because when you've got the casts on, you can't properly assess the limbs. And he had casts on 3 limbs. We did our assessment, documented that, phoned neurosurge to come back and reassess because the neurology had changed. And then he got his MRI, found that he had a spinal cord injury, and was sent up to the PA for fixation of that. So I reflected on this case because even though he was a difficult assessment, in hindsight, he probably had some things that really should have been red flags for me. So the upper limbs in particular were difficult to assess, but as soon as I touched his left upper limb, he was just in a lot of pain. And that was above the level of the fracture. It was sort of elbow to shoulder, the area that I had access to, which wouldn't have been caused by the wrist fracture, but it's all muddled up. But lots and lots of pain when I just touched his skin. So he had this like allodynia, which is lots of pain to a stimulus that wouldn't normally cause pain. And that, in hindsight, for me, is a big red flag for a spinal cord injury. Also, he said both of his hands were numb, which I think throughout his stay was documented at some points, but put down to his wrist fractures and maybe his pain response, and he couldn't really feel what was going on. He had the casts on, limited access, that type of thing. But really that fits with spinal cord injury. I don't think we would have done anything differently. We expedited his MRI. We've phoned neurosurge to come and review him, which they did. We got some feedback from one of the neurosurgeons who said, I don't think the outcome wouldn't have changed. Everything was done the right way. For me, reflecting on the clinical assessment of that patient, you just need to take a step back, start again, and do your systematic review. And one of the other learning points from this case I had for myself was that things change, injuries evolve, and if someone comes to you and says, this patient's now doing this, it's not like, oh, I've already assessed that, it's fine. Go back and assess it and start from the top and work your way through again. So a couple of big red flags for me for that case that I was able to reflect on and will change my practice in future.
How are you going to change it? Just listen to that excessive pain that just doesn't match what you're doing.
Definitely. Yeah. And just even if you have a patient that is difficult, is multi-trauma and multiply injured, just go slowly and do things systematically, step by step.
Now, some patients come to you and they're unconscious. So taking that history is quite different to the normal person that comes into the majority of us as a nurse practitioner. How do you make sure you have a wide net and then work back in? Say there's a patient that comes in with some big multi-trauma, we'll say 60-year-old male, okay, and you don't really know the mechanism of injury of what's happened preceding this event. And whether it's a medical problem, how do you work through that whilst also going through that trauma flow of making sure that his pelvis is okay? For example, a cardiac issue, say he's gone into a 3rd-degree heart block and you're rushing through and he's got a big pelvis injury that's kind of sticking out at you. How do you make sure that you go through that and not missing that 3rd-degree heart block that caused the injury in the first place?
Well, you have other teams that are helping you. So whilst trauma looks at the injuries, you have other teams like emergency helping you out with the other stuff. And often there is associated medical stuff going on. And the best example is probably the elderly patients that fall from standing for some reason, which need a surgical workup for injuries, most commonly rib fractures, but also at the same time getting a full medical workup for the cause of syncope. And we have teams that we can refer to help us do that. We also have FACEMs working with the service that are really good at doing that type of thing. But the main thing is not forgetting to do that, and asking for help. We don't have to be specialists in every area, and we have other teams that can come and help us do that.
Yeah.
Just like other teams call us when they need help with stuff.
I'm going to do some rapid fire questions right now that we haven't prepared for. And I just want you to think of the first thing that comes to your head. It doesn't have to be PG either. It can be R-rated. So we'll go e-scooter.
Oh, deadly.
Leg amputation.
Bleeding.
Paradoxical breathing.
Rib fixation. Pain.
Motorbike wearing thongs.
Dickhead.
What about motorbike wearing some rugby shorts and thongs?
Abrasions.
What about e-bike with no helmet?
Oh, scary. Just last week, we had an 18-month-old in the basket of an e-bike and they came off, and it's just like, oh my goodness. Every day we have an e-bike accident come in, and varying degrees of injury, from massive head injury resulting in death to a few abrasions or a couple of rib fractures, but massive problem that needs to be addressed. And they are trying to do that nationally from an injury prevention point of view. But yeah, just serious injury that people just don't anticipate. And because it's a pedal cycle, essentially, with a motor, people don't wear helmets. They don't wear any safety gear. They go at speeds that cars go at. And it's just a massive problem.
Yeah. You think they should be banned?
Bloody ban them. Get rid of them.
Well, then you're going to be put out of work.
There's still many silly people that get on roofs and fall off, and accidents happen every day. So we definitely won't be out of a job, but people might still be alive from it.
Your favourite trauma? Gunshot, stabbing, car accident. We don't always say favourite because
no.
it's a bit...
I don't think it's any of those. I think it's the patients that we discharge home. So in the emergency department, it's a skewed view because you have this big trauma patient that comes in. They're in the emergency department for like maximum 4 hours. For the really sick ones, maybe an hour before they go to ICU or theatre. And you think, well, that's all doom and gloom. They're not going to do well. But one of the great things about this role is I see how well patients can do with time. And the great thing about clinic is that I can bring them back and see further evolution of their progress. That's the part I love, is being able to see that.
I think as ED nurses, we forget about any other side of nursing and that continuity of care and that patient follow-up and the relationship with the patient. Recently, I found I'm in a respiratory job and I'm following these patients that have these permanent drains in that have cancer. And there's this one particular patient who I've become attached to, and it's really kind of heartbreaking watch them progress in this disease.
Yeah, but it's also good because you're there helping them through it. There's not a lot of nursing roles like mine where you get to see a patient from the emergency department right through their hospital stay and then into the outpatient space to see how they're going when they go home. So it's a privilege to be able to be involved in that journey for them. But the end part is probably my favourite part, where I can see how well they've done and how much they've progressed.
Yeah, awesome. Is there any other take-home points that you want to give to aspiring nurse practitioners or people thinking about being a nurse practitioner?
Yeah, I guess do the simple things well and practice it and find your own systematic way of doing that. So that's taking a history. You'll find your own rhythm with that, and it's like a bit of a dance. You'll find your way of doing it. And then you can template that in a note as well, and you'll never forget anything. But you'll find your own way of asking those questions and getting that information, and you'll get better and better at doing it. And that takes practice. You're not going to get it straight away. So just be a little bit kind to yourselves in knowing that you're new and it needs to be practiced, and you'll get better at it. And the same with clinical assessment. Clinical assessment will come and it will feel easier, and you won't need to look it up every time you go to do it, and you'll find your own systematic way of doing it. But it takes practice and it takes time, but you'll get there. So be kind to yourselves. Don't think that on day one you need to have all this stuff mastered, because you don't.
One last question is early closure, becoming biased as a clinician.
Yeah.
How do you maintain that in terms of, we'll break it into two types, right? So the patient that comes in who's intoxicated or just aggressive, or the family is really at you, how do you maintain that clinical professionalism and maintaining that whole picture, limiting your bias?
Yeah, well, I guess the great thing about being an NP is that you've had years and years experience of being a nurse, and particularly in ED, we've become very good at dealing with drug and alcohol affected patients and families that aren't happy with particular stuff. We've already sort of built that skill set, and that just translates across into the nurse practitioner role, where you're maybe the main one who has to manage that now. The bias thing is really interesting because there's a number of points of bias that can occur. So as a triage nurse, you get a handover from QAS, or you might get a GP letter, and the GP letter might say flank pain, query renal colic. And that might then go into the triage nurse's note, or the triage. And then that's a point of bias, because you know, oh, well, that patient's got renal colic, I'll go and work him up for that. So each time you see a new patient, my advice would be forget about that and start from the beginning. From being a nurse, from the triage to accepting the patient, from QAS, and then talking to the patient about why they're here, that changes in that time point. Yeah, with regards to bias, just start from the beginning, get your own story and work your way through there, and just be professional and courteous to families that are being a bit difficult, and don't make promises. I've learned in this role not to make promises. Don't give time frames. Don't make any promises, because often you can't fill them, and that makes people more dissatisfied. So yeah.
Cool. Thanks so much, Kate Dow, for doing this podcast. And yeah, you're amazing. And I guess if anyone wants to reach out to you, they can Instagram me, and I can pass on their details, and you can mentor them along the way.
Yeah, no worries. Happy to.
Cool. Thanks.
Thanks, Yas.
Thanks for tuning in to this episode of MP in Progress. I hope it gave you some valuable insight and inspiration as you refine your clinical reasoning process and progress on your journey. If you'd like to catch video content from the podcast, don't forget to subscribe to our YouTube channel, MP in Progress. For updates, behind the scenes moments, and more, follow us on Instagram at MP in Progress Podcast. Keep learning, keep growing, and I'll see you in the next episode.